Good evening and good morning to all those who have joined us here in the one of the very special webinar close to my heart, and a webinar to celebrate the international women surgeons and their role in the field of hand and reconstructive microsurgery. Uh, Thanks to Dr. Amy, who really made this possible. Without her and the team, this webinar would have not been such an organized event in a given a short period of time. With a few introductory words from one of the famous poet in Tamil Nadu, I would like to start this program. This was like Pattangal Sevadum Sattangal Sevadum Parinil Pengal Nadatta Vandom. Meaning to say that those days the poet thought that women will be a day will be there for women who will rule the country, rule the world, and they impose all rules and regulations. That was the dream of a poet. But now a day has come where it's absolutely fantastic to see all the pioneers in the field of hand and microsurgery is being well empowered with colleagues to say proudly to say a great surgeon, a good mother, and a great wife. All these are really fantastic to hear and from this webinar. With just few introductory words, we have Dr. Amy Moore, who is going to talk about the 5 reliable nerve transfers of upper extremity. Thank you once again. We have 2 beautiful panelists and eminent panelists in this field. The moderators, Dr. Srija Rajan, a professor from Kerala, India, Dr. Emil Lees from US. They'll be moderating this session. Dr. Amy Moore.
Great. Thank you. Thank you so much, Dr. Terrence. I would just say it's an incredible honor to be here with all of you and to be on this panel with incredible, inspiring microsurgeons, hand surgeons, and extraordinaire. It is grateful to the journal for allowing us to highlight the work that we do. I also want to just send my hearts, my prayers, and my thoughts and incredible positive energy to India and all of those who are dealing with this surge of COVID. COVID has affected all of us very intimately and professionally. And it's been now running a department that I say all the time to my team that we have to dig into what makes us whole, and that's our families, that's our talents, and that's the work that we can do every day. And so if we keep that, we can get through this, as I'm sure we all will together. So we are with you in that. But now let's take some time to talk about my favorite thing, and that is nerve transfers. I have no real disclosures for today, but I do want to thank my patients who have allowed me to share their stories. And for just reference, I recently published a CME article on these similar nerve transfers, so you can reference that there. But let's get on the same page when we think about nerve and nerve regeneration, and that is that after the nerve is injured, there's a coordinated set of events that allows that neuron to regenerate its axons to the target muscle or to the skin. And we know that there's changes both at the muscle as well as the nerve that impact the recovery of our patients. And so as surgeons, we have to be aware of that time-sensitive nature of the injury, but also understanding that we need to think what we can manipulate both at our target as well as with the regeneration. And so that's our focus as a nerve surgeon these days. We know we're limited by our regeneration rate, millimeter a day, an inch a month, a foot and a half a year. And so if you have an injury high at the neck, the time it gets to the hand is just too long. And so this is where nerve transfers were born. And to this audience, I don't need to deliberate and try to challenge you of advantages of nerve transfers. They're there, they're real, and we're using them throughout the entire body. Interest in nerve transfer has really sparked and taken off in the 1990s, and it's exciting to see where we may go with it. In my own practice, I've been applying what were the principles of the upper extremity into children with acute flaccid myelitis, and we still haven't tapped the redundant nature of the body and the power of our brain's plasticity. And so this is where nerve transfers are an exciting field. There have been multiple publications that show the improvement over nerve grafting, and the outcomes I think are attributed to this fundamental understanding that Tessa Gordon showed us in animals, in that you can lose 70% of your motor neurons before you lose function. So in other words, we only need about 30% of those axons reaching the muscle to give us good function. And that is where I think nerve transfers, why they're so good. And so if we keep that in our mindset, that we don't have to have a one-to-one relationship of the axons and entering into our muscle, we just need enough to give us the function. So what can we do? Well, we can do nerve transfers from head to toe, but today we're going to start with just my 5 favorite nerve transfers. Let's start number 1. So number 1 nerve transfers to restore elbow flexion. The biceps and brachialis, they want to move their simple lever arm, and the best and most reliable nerve transfer is to restore it by using fascicles of the median and of the ulnar nerve. From an anatomy standpoint, the fascicular topography is very sound. We know this, and when I talk to my residents, I have them draw on the sheet where were we going to find our donor fascicles, and then I show this picture with it so they never forget. So our fascicles are they look at each other, FDS, FCR, going into FCU as well. They look at each other. That's how we find them. And intraoperatively, there's no tension on these repairs. The incisions don't have to be large, but make as many incisions as you need to make sure you do the right presentation and the right performance. But the good news with this transfer is that it doesn't matter the size of the patient or the lack of potential coming to therapy. I'm a big believer in therapy, but you can get really great results from a single and double fascicular transfer, among other transfers with patients with brachial plexus injuries. High nerve injuries, this is where we're sort of on the edge. We're on the edge of what we can do with nerve transfers, because our tendon transfers are great. You can restore a lot of function with tendon transfers. And the next, my final 4, I guess, my favorite nerve transfers are showing you the power of what we can do with nerve transfers that may just make you think about, well, maybe I don't have to do the tendon transfer. If I'm in the window of time, I can restore that native muscle. So we will go through my favorite transfers within these. So number 2 and number 3 are related to the radial nerve. Now the radial nerve gets a lot of criticism because the tendon transfers are so great. And unfortunately, if you do a median to radial nerve transfer, you are basically taking away your backup plan. And that's what we get fearful of. So you have to be all in when you're going to do this nerve transfer. And this nerve transfer requires patience and a lot of therapy. So what else can we do? My next favorite nerve transfer is the thoracodorsal to triceps. I've been using the thoracodorsal branches, either the anterior or the posterior, very often. This is an underutilized donor source. If it is available, you should use it. It has easy access. It has nice length and a powerful number of axons. So here is a patient of mine, a 34-year-old, she's an ICU nurse, right-hand dominant, CrossFitter. For those of you who are eager to get your workout, people who do CrossFit are like the extreme. And so she was very much affected by that. She had this mass in her axilla that was excised. And unfortunately, she woke up with lack of use below the level of her axillary takeoff. So no triceps and no radial nerve function. Couldn't work and couldn't work out on her dominant arm. So I took her to the operating room, found that her radial nerve stump was tied off. And I decided that her triceps were very important for the work that she does and for her quality of life. I used the anterior branch of the thoracodorsal nerve, transferred it directly to the triceps. I grafted for the pain. She had 10 out of 10 pain. You couldn't touch her arm. I grafted her 9-centimeter ulnar nerve grafting for her radial nerve. If she got anything back from this, great, but that wasn't the intent. The intent was then later, which we did 2 weeks later, actually 2 months later, we did her median to radial nerve transfers, and that is using the FDS to ECRB, capitalizing on tenodesis, and FCR to PIN. Here she is at 1 year. You can see her triceps are working strong. She's lifting more weight than I would ever intend to, and her finger motion is fluid. So this is what we get from radial nerves. We get the fluidity, the ability to use independent function without wrist extension and finger extension happening together. She is back at work. She is clearly working out. And I'm excited when my patients come back with this great outcome. And I haven't had to be in the scenario where, oh, I need a backup plan. So that is for your radial nerve. Here's another example of a gentleman that I did thoracodorsal to triceps. And you can see, here's going to show it. He had no triceps. So I did a medial nerve to axillary, and you can see crossing his body is the strongest for his raising his shoulder. But there is his triceps against gravity, and incredible quality of life returned for an electrician who needs to work above his head to perform his career. The median nerve carries number 4. This is a really fun nerve transfer. It's based on the similar anatomy of the median to radial, but ECRB to AIN, this is a patient who had an isolated median nerve, and you can see the AIN deficit with lack of thumb and index finger flexion, lack of opposition, which I treated with the tendon transfer years ago, but now I would try to Patel's hypothenar to thenar nerve transfer. But the anatomy and the dissection, you have to be aware of that LABC. The LABC is working. You can use it to restore sensation. You get deep, you find your superficial branch of the radial nerve, which is lying within, and right lateral to it is the ECRB branch, and there are usually 2. The median nerve, the AIN, comes off on the radial aspect, and we can go directly without any tension, the ECRB to AIN. Here's the incision on my patient, 5 months from his injury, identifying his nerves, both the donor and the recipient. I used LABC to the side to restore sensory. And here he is at 1 year. His exam video, it tells you he did not get any up therapy. He came back because there was a bulge in his chest he wanted removed. And I finally was able to get my outcome. But this is him. He was a young gentleman. The next gentleman was 76 years old. I get the question all the time, too old. My pre-op was his first visit back in the OR, from the OR, but his 1 year post-op is this. I do not believe age is an issue. I think that all nerves will recover. They're just going to be slower as people age. And I offer nerve transfers to all age groups. The ulnar nerve, in my final few minutes, or 2 minutes, is honestly, I couldn't get without saying about the supercharged nerve transfer. Patients, incredible dysfunction and lack of dexterity. Here's a 7-year-old who had an isolated axillary, an injury to her axilla, took out her ulnar nerve. She's a professional guitarist, both equally devastating. This one also had his radial nerve avulsed from the muscle belly. A supercharged nerve transfer is taking the donor to the side of the recipient that allows this active axons, this active Schwann cells that are healthy. So if we go back to what really matters for recovery, it's that distal nerve Schwann cells. It's the increase in time and the time needed for your motor implants to have that electrical input, and a supercharged nerve transfer allows for this, but it doesn't stop your proximal regeneration. So it is what I've been employing. If a patient's going to recover, or I think it's going to recover, or I repaired proximally, I will add a supercharge. We showed it in the lab, proof of concept. We put it in an injury model and showed we can augment function and force. We cut that additional source of axons, and you can see that there was still improvement in function. And in my children, the child, I grafted proximally. I did a supercharged nerve transfer distally, I added this from my most recent publication just to show that all we're trying to do is spread out along those fascicles of the motor component, this supercharged into side. You make a large epineurial window and you sort of stuff it in, but not too tight. And you don't need to injure those recipient axons at that level. The axons will make it to the target. At 14 months, here's her result. She's able to extend. She's back to playing the piano, which I think is a really high dexterity for the ulnar nerve. And here is the professional guitarist. He rafted proximally, a supercharged distally. And I'm not sure if you can hear, but this will be good for Dr. Powers, who's helped me with his case and I think would recommend, would also recognize him. You can see that his extension of the small and ring finger are present. Can't do that with ulnar nerve. So we looked at our patients, showed that you can increase strength with using the supercharge. Since then, this has been multiple other groups showing its possibilities, and so I encourage you to consider it. I've just done a whirlwind of favorite nerve transfers of the upper extremity, and thank you so much for your time. My final thoughts are nerve surgery is fun. You know, you have to find your inspiration at times, and that comes from your patients. If we intervene early, you'll get better results. But the most important part is think about what we can do to help our patients, and the sky's the limit. So thank you so much. I'm really grateful to be here today.
Thank you, Dr. Amy. It was really fascinating and enjoyed your talk.
Thank you.
I think we should have given a topic, rather 5 variable nerve transfers which really worked well. We should have given a topic, all nerve transfers will work under you, because those are the nerve transfers which we find really amazing and the functional outcomes are really good. To quickly sum up, Dr. Amy, thanks for joining us here. Please stay tuned. We have a lot of questions from the panelists. Most of us knew well about Dr. Amy Moore. Quick few words. One visiting professor, the American Society visiting professor. A lot of credits goes to Dr. Amy Moore. One of the pioneers in the field of nerve and reconstructive surgery. Thanks for joining us. Dr. Amber.
Hey everybody, those are phenomenal results. Thank you so much for sharing those. It's my pleasure to introduce our next speaker, Dr. Hollie Power. Dr. Power is an assistant professor in the Division of Plastic Surgery at the University of Alberta in Edmonton, Canada, and she completed her training in plastic surgery at the University of Alberta, followed by a fellowship in hand and peripheral nerve surgery at Washington University in St. Louis and a microsurgery fellowship at the Asan Medical Center in Seoul, South Korea. Her practice is currently focused on hand and wrist surgery, peripheral nerve, and microsurgery. Welcome.
Thanks very much. Can you guys see my screen? Okay.
Yes.
Thanks for that kind introduction, Amber. I echo Amy's comments. I'm very honored to be here and asked to participate in this illustrious panel. So thanks very much, Dr. Jerome, and to the journal. And thoughts and prayers are with you guys in India. Hopefully things start to improve soon. So today I'm going to talk about beyond the elbow, advances in the treatment of ulnar neuropathy, and specifically I'm going to talk about cubital tunnel syndrome. So outline for my talk, I'm going to talk a little bit about the classification of cubital tunnel syndrome, surgery beyond the elbow that we can perform to improve our results, as well as postoperative electrical stimulation. So we all know that cubital tunnel syndrome is the second most common compression neuropathy, and profound functional disability can occur in severe cases. So treatment, of course, usually we start with non-operative management, but for patients with severe disease or those that fail non-op management, we have several surgical options that are available. The most common being in situ decompression or ulnar nerve transposition. Now, the operative management of cubital tunnel syndrome remains controversial, and many authors have attempted to answer the question, what is the best surgery at the elbow? So this is a bit of a busy slide, but you can see here that this is a summary of 9 recent meta-analyses that examine the outcomes between various surgical techniques. The studies included are heterogeneous, and the outcomes actually are highly variable within groups for the studies included here. And interestingly, only about 50% of the studies used an established classification system to grade disease severity. So not surprisingly, they weren't able to find any significant difference in clinical outcomes between procedures. But this is not a talk to convince you about what is the best operation to perform at the elbow. Instead, I want to discuss other advances and sort of food for thought in the management of cubital tunnel syndrome that I think might help improve our outcomes, especially for the severe cases. So let's look at a clinical case. This is a 51-year-old male with intrinsic atrophy, severe pain, and you can see this is his nerve conduction study. You can see that he has a very low CMAP amplitude in the FDI and ADM, as well as reduced conduction velocity across the elbow segment. So if we consider how do we classify disease severity, the commonly used classifications rely on clinical symptoms and signs. So that would be the McGowan and Dellon classifications, which are most commonly used, at least in North America. Neither of these classifications include electrodiagnostic parameters, whereas the Akahori and Gu classifications, which I think are more commonly used in Asia, they do consider electrodiagnostic parameters, but only changes in conduction velocity. We published a study looking at 83 patients with cubital tunnel syndrome and found that changes in CMAP amplitude predicted preoperative functional impairment, whereas reduced conduction velocity alone did not. And Amy already showed this figure, but I'm going to show it again because I think it's really important. We know from Tessa Gordon's work that we can maintain near normal muscle function with loss of up to 80% of the motor unit pool, and that's due to collateral sprouting. So on our nerve conduction study, CMAP amplitude is a surrogate for axonal injury, whereas conduction velocity is a marker of demyelination. So preoperatively, surgeons can evaluate these metrics to accurately estimate the time course and completeness of recovery. And with the limitations of those existing classifications in mind, we are publishing a paper this year in PRS where we have expanded the classification for cubital tunnel syndrome. And when we compared this revised classification against established classifications in a retrospective cohort, we found that it better predicted DASH score improvement after ulnar nerve transposition. So this is what the classification entails. So you can see that we've added pathophysiology of nerve injury, those classic signs and symptoms, as well as electrodiagnostic parameters. So for example, if you have a patient with reduced conduction velocity, but normal CMAP amplitude and EMG, you know that this is consistent with focal demyelination, and you can reassure the patient that their symptoms should resolve within about 3 months after the surgery as the nerve remyelinates. Going back to that figure on function versus motor neuron innervation, you can see our revised classification overlaid. And if you note, there's quite a large spectrum of disease in the moderate category where you can see quite significant axonal loss before you see a reduction in function, whereas a patient with severe disease has profound loss of the motor neuron pool to the point that recovery will be prolonged because you need to wait for axon regeneration to occur, and in many cases it will be incomplete. So this is honestly like a little bit of a boring topic for hand surgeons. Like we want to do surgery, not really think about the nerve conduction aspect of it, but I think it's actually really important to consider and will allow us to better understand which treatment options will benefit which patients, such as, for example, adding axons in the case of a severe neuropathy with a nerve transfer. And I think it'll also actually allow us to accurately stratify patients and compare outcomes for different treatment options. So going back to the case that I presented previously, of course, this patient would fall into the severe category with his symptoms and very low CMAP amplitude. And in my practice, this patient would get an ulnar nerve transposition because of the severe neuropathy. Whereas for mild moderate cases, I would usually always start with an in situ decompression and then decide if a stabilizing flap or transposition is needed intraoperatively. But like I said, this talk is not to convince you about the type of surgery at the elbow. Instead, I want to focus on what we can do beyond the elbow to improve function. So we have several adjunctive procedures that we can offer patients with severe disease that can improve their functional outcomes. And I think with these procedures, the traditional dogma that severe compression portends poor outcomes is no longer true. So the most popular of those adjuncts is the AIN to ulnar motor end to side nerve transfer, which Amy already introduced. But I'll just make a few more comments on that specific to cubital tunnel syndrome. So I think the indications for using this procedure in cubital tunnel syndrome are very specific, and we previously published our algorithm with Dr. McKinnon when we use this transfer. Essentially, if the patient has intrinsic weakness, reduced CMAP amplitude, ongoing active denervation of the intrinsics as well as a normal donor, that would be when this transfer is indicated. So this would be my standard surgical incision. I would always release Guillaume's canal, as the leading edge of the hypothenars can be a secondary point of compression for the deep motor branch, and you want to make sure you have a clear highway for regeneration. The FDP origin should be divided off the ulna. Of course, the PQ needs to be opened along its length, and then any crossing vessels overlying the AIN need to be divided to allow that tension-free transposition. The motor component is always sandwiched between the two sensory components, and often in cubital tunnel syndrome, you can actually stimulate it with a handheld stimulator, or alternatively, you can trace it back from the hook of the hamate if you want to be sure. Then you create an epineurial perineurial window, and then perform your tension-free coaptation. You want to make sure that you can move the wrist and fingers with no tension on the coaptation. Another important aspect of this transfer is the postoperative rehab. So this wonderful paper written by Lorna Kahn and Amy Moore is a great summary of the donor activation focused rehab approach. And essentially what that does is it recognizes the altered neural pathways of the nerve transfer and it works on activating it. So this would be an example of a 12-month post-op result. And so the patient, you notice, actually has stronger intrinsic activation with his forearm in pronation. So he's still using co-activation of the donor compared to supination where it's weaker. And then likewise, you can see that his lumbricals are pretty easy to overcome with the forearm in supination, and then in pronation, they're a bit stronger. And this phenomenon goes away over time as the patient learns to activate the recipient without co-activation of the donor. A lot of literature, and Amy highlighted a few of the studies already, have looked at outcomes after this nerve transfer, but specific to cubital tunnel syndrome, Chris Doherty and Doug Ross looked at 30 patients with severe compression neuropathy who had an ulnar nerve transposition and the nerve transfer, and they found that 73% of their patients achieved at least an MRC grade of 3 at 18-month follow-up. Now, in terms of outcomes, I guess maybe that doesn't sound that impressive, 73% achieved anti-gravity, but if you compare that to other large series looking at outcomes with surgery at the elbow alone, so one paper that comes to mind is Bartels, I think in 2005. They looked at 24 severe patients and only 13.5% of their patients achieved an MRC grade of greater than 3. So it's actually a pretty big improvement over standard treatment. And more recently, Jana Dengler and Dr. McKinnon looked at 42 patients with severe cubital tunnel syndrome who had an ulnar nerve transposition and the nerve transfer, and 79% of their patients recovered at least an MRC grade of 3 intrinsic strength. 7% had no improvement. And what I found really interesting is that there was no CMAP amplitude cutoff below which the nerve transfer was not successful. So other things that you could do beyond the elbow, you can consider doing a tenodesis of the long finger FDP to the small and the ring and small finger FDP to improve DIP flexion. And you could improve ring and small finger sensation by using the cross palm nerve grafts from the median to the ulnar nerve. John Felder and Dr. McKinnon looked at their outcomes, 24 patients with severe ulnar neuropathy, and found that at 1 year post-op, 87.5% of patients had achieved at least diminished protective sensation. And Dr. McKinnon described her use of these adjunctive procedures in 49 patients just this year. And those who had adjunctive procedures had greater improvements in DASH score compared to a retrospective cohort that underwent surgery at the elbow alone. So clearly these adjunctive procedures can improve outcomes in our patients with severe cubital tunnel syndrome. And I think that they definitely should be considered and are a game changer for patients with severe cubital tunnel. The last thing I'm going to talk about is electrical stimulation. So despite our best practices with surgical techniques, when we have severe neuropathy, often our recovery remains incomplete. And so a lot of work has went into looking at ways we can boost the innate regenerative capacity of the nerve. And electrical stimulation is one that has shown great clinical promise. So this is stimulation that's applied directly to the nerve. It's not transcutaneous. And it was popularized by Tessa Gordon's group in the 90s. Based on a rat model of femoral nerve cut and repair, they found that electrical stimulation enhanced axonal regeneration and preferential motor reinnervation for all stimulation durations. And that was anywhere from 1 hour to 2 weeks. And just last year, my group actually published a randomized controlled trial looking at 31 patients with severe cubital tunnel syndrome. 11 underwent in situ ulnar nerve decompression alone, and 20 underwent surgery plus 1 hour of postoperative electrical stimulation. We followed them for 3 years, and we found that patients who underwent stimulation had 2 times more functional motor units by 3 years post-op. And functionally, they recovered 65% greater pinch strength by 3 years post-op. This is an example of the intraoperative setup. So this particular case is a traumatic median nerve laceration, but you can see the needle EMG electrode, which is our stimulating electrode. It's implanted adjacent to the nerve that you want to stimulate, and then it's fed outside the surgical dressing, and in the recovery room, the patient gets hooked up to the stimulator. We do a 1 hour session. You can see that this is a fairly archaic looking stimulator. This is a research stimulator called a GRASS. We do 1 hour set at the tolerance limit. It's not painful. And then the electrode is removed at the end of the stimulation session. Other groups have been working on alternate delivery techniques. So the Washington University group, Dr. Moore's former institution, they have shown efficacy using the checkpoint device in a rat model. And I believe Dr. Moore is also working on a human clinical trial using this device. So excited to see those results come out. And then most recently at the ASPN meeting in January, the WashU group demonstrated efficacy with just 10 minutes of stimulation instead of the full hour. And I think that's a really important contribution since, of course, time is money in the hospital, and the shortest duration we could apply would be ideal. So there's a lot of exciting work in this field, and I'm excited to see that its clinical use become more widespread. So just to conclude, I think to compare treatments for cubital tunnel syndrome, we need to use robust preoperative classification that considers the nerve pathophysiology, signs and symptoms, and electrodiagnostic parameters. In severe cases, we should consider treatment options beyond the elbow to optimize our outcomes. And brief post-op electrical stimulation can enhance functional recovery beyond what surgery alone can achieve. Thank you very much.
Thank you, Dr. Hollie Power. It's amazing, the concept of revised robust classification based on your electrodiagnostic study in cubital tunnel, and the results of adjunctive treatments. Obviously, around 70 to 80% have M3 power, and of the late slides about intraoperative and stimulation and postoperative stimulation are really interesting and intriguing for us. Thank you once again. We have a lot of questions here. Dr. Shija.
Yes, thank you, Terence. I will introduce the next speaker now. I've got great pleasure in introducing Dr. Rosa Morro. She's an orthopedic surgeon and hand surgeon in trauma unit, Hospital Tendon, Barcelona in Spain, and also Hospital Matthew Orfila, Menorca in Spain. She is also professor of human anatomy in Faculty of Medicine at the University de Barcelona. She will be speaking on the spastic hand, tendon transfers, and beyond. Over to you, Dr. Morro.
Thank you very much. I'll share my my screen if I can. Can you see it?
Not yet.
Can you see my screen? No? Oh, okay. Now, okay. Okay. First of all, I want to apologize for my English. It's not my first language, but I'll try to do my best. And second of all, thank to Dr. Moore and Dr. Jerome and all the organization for inviting me and for letting participate in this session, which is being very interesting. And now we'll change the topic. We'll start, we'll talk a little bit about the spastic hand and the possible surgeries or possible treatments we can do. Spasticity or dystonia are caused by a lesion in the central nervous system. The etiology is very wide, from traumatic brain injuries, strokes, brain tumors, cerebral palsy, spinal cord injuries, many etiologies, and each of which has a very it's a specific features which we must keep in mind. The common pattern of deformity is the shoulder in adduction and internal rotation. The elbow is in flexion, pronation of the forearm. The wrist is in flexion and ulnar deviation. The fingers are flexed and the thumb is in adduction and flexion. However, each patient is unique and we must perform a very thorough physical exam to determine which muscles are spastic and which are not, and which are paralyzed and which are functioning. We can start with non-surgical treatments such as stretchings or splints or botulinum toxin. The botulinum toxin, besides being a treatment, we can also use it as to foresee the results of a possible surgery, and it can also help us to determine the amount of spasticity or retraction we have in a determined deformity. Among surgical treatments, we can do neurotomies, tendon elongations, tendon transfers, and different kinds of joint stabilizations. I don't know why it's not okay. Starting with the deformities of the hand, Hollie classified it into intrinsic deformities when we have flexion of the MP joints, and extrinsic deformities when there's a flexion of the IP joints. And going on with the extrinsic hand, we can grade it into 3 progressive grades. Grade 1, there's a spasticity only of the FCU. In grade 2, we have a spasticity of the flexors of the wrist and fingers. And we can divide it into A, when the extensors are functioning, and in B, when they are paralyzed. And grade 3 are those severe deformities in flexion of the wrist and fingers. In grade 1, there's only spasticity of the FCU, so we perform a tenotomy of this tendon. We usually resect a small piece of this tendon to avoid recurrences. In grade 2A, where we have a spasticity of the flexors of the fingers and the wrist, but the extensors are working, We also perform a tenotomy of the FCU. And we also do an epinorrectomy of the epitrochlears at the level of the elbow. And for the fingers, we do an intramuscular elongation of the flexors of the fingers. For grade 2B, where there's the extensors are paralyzed, we do the same we've done in grade 2A, a tenotomy of the FCU and epinorrectomy of the epitrochlears, and elongation, intramuscular elongation of the flexors of the fingers. And we use the flexor, the FCU, to transfer it to the extensor digitorum, so we can strengthen the extensor of the extension of the fingers. This is a clinical case of a patient who underwent this kind of surgery, these procedures. And as you can see, he has a very useful, a very functional hand. He can even hold a pen and write. He needs some tricks like some flexion of the wrist, but he has a very useful hand. In grade 2B, there's another option. We can do a sliding of all the muscles, of all the flexor pronator muscles. We detach it from the epitrochlear, and we open the hand and the wrist and just leave them wherever they need. We don't reattach them. And the advantage of this technique is that we don't lose the strength of the muscles as we do when we perform tenotomies. In grade 3, we have these severe deformities in flexion of the wrist of more than 90 degrees. Here, maybe you could think that the flexors of the fingers are not affected, but at the moment we put the wrist in neutral position or almost neutral position, the fingers will flex immediately. So we also must perform some procedure on the flexor tendons. In grade 3, we do all we've been talking about in grade 2, the epinorrectomy of the epitrochlears, the intramuscular elongation of the fingers, of the tendon of the fingers, and we do a tenotomy of the FCU, which will transfer it to the extensor digitorum, and we also will transfer the FCR to the extensor carpio radialis brevis to strengthen both extension of the fingers and the wrist. When the intramuscular tenotomy of the finger flexors is not enough, there's another procedure called STP, which can help us. It consists in cutting the flexor superficialis distally and the flexor profundus proximally, and then we suture together the proximal stem of the superficialis with the distal stem of the profundus, and this way we can gain up to 6 or 7 centimeters in length of the flexors to be able to open the fingers. When soft tissue procedures are not enough to control the deformity, we can always perform wrist arthrodesis. Classically, it's been contraindicated in this kind of patients because we lose the tenodesis effect. But if we use some tricks, such as leaving the wrist in a slight flexion, we can have a very useful or quite useful hands. Moving on to the fingers, we can have an intrinsic plus deformity, a swan neck deformity, and an intrinsic minus deformity. In the intrinsic plus deformity, the problem are the interosseous muscles, so we must release them either from its origin in dorsally or in their insertion through a palmar approach. For the swan neck deformity, we must keep in mind that the physiopathology of this deformity in non-neurological patients is different from the neurological patients, so we can't treat them in the same way. For the neurological swan neck deformity, a good procedure is cutting the flexor superficialis proximal to the MP joint and fixing it to the first phalanx with a slight flexion of the IP joint or of the PIP joint. So this way we avoid the hyperextension of this joint. For the intrinsic minus deformity, there's a very wise procedure called Bastos Mora. It cuts the flexor superficialis distally from its insertion in the base of the middle phalanx, and it fixes it reattaches it to the proximal phalanx. So this way no longer will do flexion of the IP joint, but flexion of the MP joint, and will correct deformity. The thumb is always in adduction, and we can classify it into 4 types depending on the position of the rest of the joints. In type 1, we have only adduction. In type 2, we have flexion of the MP joint. In type 3, there's a hyperextension of this joint, of the MP joint. And in type 4, we have a flexion of the MP and IP joints. These are some clinical examples. Type 1 is not very often. And we usually have or type 2 or type 4. These are both type 4, which is usually, we call it thumb in palm. For the adduction of the thumb, we must do a tenotomy of the adductor pollicis, either proximally or distally in its insertion in the first metacarpal. And for strengthening the abduction, we can transfer the brachioradialis to the abductor pollicis longus. Sometimes we need to do all Z-plasties of the first web space because of retraction of the skin. For the hyperextension of the MP joint, we must keep in mind the amount of deformity we have. When we have less than 20 degrees of hyperextension, we usually can control it by advancing the volar plate. But when we have more than 20 degrees, a fusion of the MP joint should be performed. For type 4, where we have flexion of the MP and IP joints, we should do a tenotomy, an intramuscular tenotomy of the flexor pollicis longus. And to strengthen the extension, we can transfer the brachioradialis to the extensor pollicis longus. To finish, I just want to introduce the hyperselective neurotomies. This is a very old technique that has renewed its interest because of the introduction of the intraoperative nerve potential register. It's indicated when there's only spasticity with no retraction, otherwise it won't be useful, it won't work. And it consists in finding the specific fascicle and the motor branches of the affected muscles and cut some of these branches. What is not still known yet is the amount. It's not exactly known the amount of denervation we have to do in a muscle to just weaken it, but not completely denervate it. This is a clinical case of a girl with cerebral palsy. You can see the usual pattern of flexion of the elbow, wrist, and fingers. And these are the clinical, the intraoperative pictures. We found the musculocutaneous between the brachialis and the biceps. We did the intraoperative register to localize all the branches to the brachialis and to decide which branches should be cut, and we cut some of them. And this is the clinical result. As you can see, because of the scars, we perform other procedures in the hand. Basically, we did tenotomies and tendon transfers, and as you can see, we can have a very quite useful upper extremity, taking in mind that the type of patients we're talking about. And to finish, just saying that the goals of all these surgeries are to improve the muscular balance and correct most of the deformities. With this, we can improve function, and with this, sometimes we can improve the aesthetics and even the psyche of the patient. And all this is just to facilitate the patients and their families' lives. Thank you very much.
Thank you, Dr. Morro, for showcasing all the procedures by how much we can return the function to such a deformed children. And it's a really fascinating work, but I think it requires a much higher degree of expertise to first make the decision on when to operate, what to do for each individual patient. And that is where the whole crux of the knowledge about spastic hand is. I'm sure we'll have to expect a lot of questions on this, which we'll be taking after this. So may I proceed to introduce our next speaker? Thank you. May I introduce Dr. Sonya Agnew. She is the Association of Plastic Surgery at Loyola University in Chicago. She is also interim residency and fellowship director of plastic and reconstructive surgery. She has special interest with many publications in reconstruction of hand, endoscopic carpal tunnel syndrome, Dupuytren's disease, and so on. Today, she will be speaking to us on microsurgical flap coverage of the upper extremity. Welcome, Dr. Sonya.
Morning, everybody. Let me just make sure I'm sharing the screen here. Okay, can everyone see my screen?
Yeah.
Great, thank you. Well, good morning. Thank you for the introduction. I am extremely honored to be a part of such a spectacular group of surgeons. And I will echo the thoughts of others that my thoughts and prayers are with you in India and throughout the world that are suffering right now due to the pandemic. I'm going to proceed by speaking this morning on the microsurgical reconstruction needs for folks with limb salvage. I'm going to talk about the indications for flap reconstruction in patients who have severe injuries of the upper extremity. And I'll be doing a lot of case examples, so lots of pictures. Speak about special circumstances and tips and tricks to avoid complications. So who needs a flap? The obvious people who need flaps are those with soft tissue defects with exposed white structures such as bone, tendon, and nerve. And these are patients who have often not only a simple skin need, but composite defects that require staged reconstruction. Specifically those with electrical injuries in the instance where they often end up with soft tissue loss in addition to bone, tendon, and nerve loss. The folks with mangled extremities, very large bone defects, patients with joint contractures that are not amenable to splinting, and oftentimes patients who have digital loss from amputations undergoing free tissue transfer from toes will need additional soft tissue coverage to prepare for toe transfer. So I'm going to start by highlighting a patient who had a thermal injury. This is a young gentleman who was at work and his forearm and hand were pinned between two plates that were 450 degrees Fahrenheit for over 10 minutes, resulting in the obvious soft tissue defect on the dorsal forearm with exposed distal ulnar joint, dorsal carpus, loss of his extensors, and a very large soft tissue defect. So his needs were obvious coverage of his joints, overall wrist stability given the loss of dorsal structural support of the wrist, and finger and thumb extension. So in order to address these, in the order I chose was to provide a stable soft tissue coverage with initial management of the exposed bone using antibiotic cement beads. And you can see on the left side, this is a free anterolateral thigh flap that I used. In North America, patients are on average larger, and their anterolateral thighs are thicker. So this has to be taken into consideration when planning the total number of cases that are required to close the defect, and also how tight you want to close the defect, because oftentimes the tissue is sort of lifting off of the dorsal hand. Next stage for this patient was to provide provisional stabilization with an external fixator and a definitive transition to a total wrist fusion with iliac crest bone grafting. Finally, I chose to transfer his pronator teres with an interposition FCR graft to his extensor communis tendons in order to provide active extension of the digits. Some pearls that I learned from this were that in general, these patients require multiple operations. In particular, this patient had 12 operations, including debridements, over one and a half years. Ultimately, he was able to wean himself off of narcotics completely with a stable wrist, but active finger extension was not really ever possible for this patient. He ultimately ended up with a more neutral posture of his MP joints, which allowed him to grasp objects easily, but did not have significant excursion, largely because he did not have the advantage of tenodesis in the setting of wrist fusion. So in general, I want to mention that these injuries, thermal injuries, are often a larger zone of injury than you may think. You have to have realistic goals for patients. And under promise finger range of motion is a mantra that I think for these large soft tissue defects, you have to explain to patients over and over again. Moving on to the second case, this is a 31-year-old gentleman who touched a high voltage power line with his left hand. Very fortunately, he did so in front of a firehouse and was immediately resuscitated because he was in VTAC. You can see the entry point in his left forearm. I was not initially consulted on this patient, and over the course of the next month, skin that had been grafted eventually died away, revealing the soft tissue defect that you can see on the right of this screen here. He was, after debridements, was noted to be missing about 10 centimeters of his median nerve, all of his finger and thumb flexors, and obviously with the median nerve defect and the loss of flexor tendon, he had no ability to oppose his thumb. The order of operation for this patient was to debride. I used a free anterolateral thigh flap to resurface the skin loss, and ultimately went on to do Z-plasties to allow the thumb more neutral positioning with a EIP opponentsplasty. This was a staged reconstruction of the finger flexors using a hunter rod and his more proximal active muscle bellies, retaining some strength. And after 2 years and 8 operations, you can see the image in the center to the image in the right is the only active flexion he has. He uses his left hand for kayaking. He is about a 6-pound pinch strength, but he's still on narcotics. And so this highlights the severity of high voltage injuries. There is a significant amount of damage directly to the muscles in the hand and forearm. Intrinsic contracture is a very big problem given the length of the median nerve defect. And because the tendons were grafted to the level of the carpal tunnel, in general, his excursion was low. So reminder to set realistic goals for these types of patients because they are challenging. I'm going to skip through bone defects. This is a patient who has a recurrent giant cell tumor of his distal radius, on whom I was consulted after the image on the right. You can see here, complete loss of the distal radius. He's 436 pounds. And though he has a mid-carpal joint, I recommended a total wrist fusion with the use of a free fibula. And as you can see, again, very, very thick adipose layer, which poses some challenges for inset. But ultimately, after debulking, the patient went on to have a very nice result. Similar case with a chronic osteomyelitis for a patient who's a former IV drug user. Very large defect in her radius and ulna. We converted her to a one bone form with a free fibula. Did very well. But unfortunately, 2 years after her surgery, she relapsed and began injecting drugs into the middle of her fibula. You can see the proximal and distal ends have integrated really nicely with the proximal ulna and the distal carpus, but she fractured in the middle of the graft. So we took her back and revised her and replated her. Just pearls for this, just remember that you need to take more skin than you think you do for extremity defects in order to cover the anastomosis. And a reminder that patients with a history of IVDU have a very, very high recidivism rate, and keeping this in mind is important for patients as well. This is a patient who required free toe transfer. He was referred to me after his debridements. He had integra over the radial aspect of his hand and a functional CMC joint, so I thought he was a good candidate for toe transfer, but I was concerned about the lack of soft tissue envelope that was available to cover the anastomosis. So we went on to stage this with a radial forearm flap, and then proceeded with a second toe transfer for the patient's, it was the patient's preference to do so. And after debulking of the flap and a tenolysis, is working currently on achieving a strong grasp. I would say that a pearl for that one was just to be keeping in mind that the overall excursion of a transferred toe in this setting is not going to be as great as you may want it to be for many reasons, and setting realistic patients' expectations as well as expectations on the surgeon's point is important as well. And then I'll finish off with a first web space contracture. This is a patient on whom I would have considered a distally based radial forearm flap to resurface the first web space, but he did not have a patent arch. And so we used a free lateral arm flap to correct the contracture, and he was very pleased with his overall outcome. I'm going to skip through the mangled limb because we only have a couple of minutes left, but I want to highlight the issue specifically with mangled limbs in terms of expectations, aesthetics, and then never forgetting that amputation is an option. And it's hard to know whether or not prosthesis and amputation is better than salvaging of native structures. So this is a 60-year-old woman who's crashed into a wall. She was drunk driving with a segmental humerus defect and a severe crush injury to her hand. Her needs included a coverage of exposed tendons and hardware in the hand. And fortunately, she had a surprisingly patent arch, and I was able to cover her dorsal hand with a reverse radial forearm. A pearl here is to pin the MCP joints in flexion to avoid the later extrinsic contracture that can limit your results. So she has some work to go down the road. I'll summarize at the end here just by sharing with you that you can guess how many operations you're going to need for these patients. Take your time to consider the best plan of action and share that plan with your patient. Don't try to hit a home run. These are marathon cases, and you'll get to know these patients over the course of years. And form a team. So these are people that I work with on a regular basis. I ask partners to help me with large cases. I have the great fortune of working with excellent residents and fellows. And I stand on the shoulders of the people who trained me at University of Washington and Northwestern University, and strongly lean on my partners like Dr. Van Devender for their support and advice. So with that, I want to thank you for your time. I appreciate the opportunity to speak with you today, and thank you very much.
Such impressive cases. Thank you, Dr. Agnew. I think that they're the kind of things that many hand surgeons have nightmares about seeing one of, and you clearly treat many of them and treat them with extraordinary expertise. So thank you for sharing those.
Thank you.
Thank you very much. We have questions from the attendees. Probably we can take a few questions here. Dr. Hari Venkatrami is one of the finest microsurgeons whom I know in India. He has a question. What is the role of nerve transfers in Parsonage-Turner syndrome? Probably to avoid the audio clash, we can have one speaker at a time. Thank you.
I would love to speak on this. Thank you. Thank you for the question, and thank you all for tuning in. Great presentations also to my other panelists. Like, so excited, so proud of all of you and what you do. Very inspirational. As for nerve transfers and Parsonage-Turner, there's a lot of controversy. That's why you asked the question, because there are advocates of just decompressing the nerve, or Scott Wolf has been very aggressive with going in and teasing open the nerve, which he describes as, I think, more of these circular areas. But I have done nerve transfers, and I wait to 6 to 7 months to get an electrical study to show that there's nothing recovering. And then I intervene. When I first started practice, I was receiving all these patients who needed tendon transfers who did not recover Parsonage-Turner. And therefore now, because I can get a great result from nerve transfers, I nerve transfer them. And I wait, though it's late, 6 to 7 months, the earliest I would intervene.
Thank you. Thank you. Any comments from the other panelists?
I agree with what Amy said. That's also what I would do. If they're not getting recovery, then no reason not to do a nerve transfer.
Thank you. The other question is from Professor Dr. Bandari, who does a really voluminous work in brachial plexus, and he's done an incredible job in our India. So his question, in bifascicular nerve transfers, what he means in the elbow flexion, do you still believe in isolating the fascicles of FCU and FCR?
I will speak because I can't help myself, and I just can't. But I do focus on those fascicles. However, and I think I mentioned in the chat, I really care about what I'm leaving behind. I want, when I use a handheld device, I want to make sure at the lowest setting, it gives me strong function for my donor. And then once I isolate that donor, whether it's redundant doing all the motions, because there is so much redundancy there, I just make sure what I'm leaving behind is strong and that I'm not taking one function away. So not so much that I'm like, oh, it's only wrist, because every fascicle has a little wrist, little fingers. I just make sure that what I'm leaving behind is strong.
Thank you. Yeah, Dr. Shija, please go ahead.
I've got a couple of questions. One is from Dr. Praveer Bharadwaj. As Terence knows, he's done considerable work in spastic hand and nerve transfers. So he has conveyed one question. One is about the SOMSAC transfer when you are transferring triceps branch to axillary nerve. With the classic SOMSAC, it was long head. But now there is a change in thought that because it's spanning biarticular two joints, the long head should be spared, and that the thought is going towards a modified SOMSAC. So I'd like to know the panelist experience with it. Do they prefer the medial head now, or is it the long head?
Hollie, do you want to answer?
Was the question more directed to treating spastic limbs?
No, actually for nerve transfer and brachial plexus, would you prefer to have a classic SOMSAC with the long nerve to the long head of triceps being transferred to axillary nerve? Or would you have it changed to medial head of triceps branch to axillary? What is your experience?
Most commonly, I think the medial head is what I would use. I don't know about other panelists.
Well, I do want to speak again. I think the long head is so strong, and I like to keep it. And then I take branches. I mean, there's multiple branches to triceps. And so I take either to lateral or the medial head is the most, because there's usually 2 long ones that can get me there, and I don't have to worry about tension. And I'm now supercharging my shoulders. So if there's any recovery in deltoid, I will supercharge using that medial triceps. Not one patient has had any trouble. And so I do love that long head for all the rest of the stabilization that it provides to the shoulder. So I tend not to touch it.
I got one question. This is my question. When you're doing end to side transfer by creating epidural windows, and when we are doing the cross palm transfer for sensory recovery by doing side to side, what actually are the mechanisms by which the nerve regeneration and the collateral sprouting, what are the actual mechanisms involved?
Sure. So we looked at this in animals, and we know with sensory nerves that they sprout spontaneously if you just make an epidural window. So their sensory nerves are very smart. And we don't really know why they recover so well, or why, if you knock out, so somebody, for example, if you were to have a radial nerve injury, your LABC and your posterior cutaneous grow into that area. So there's lots of studies showing that the brain can detect what sensory loss is, and the sensory nerves will sprout spontaneously. If you make an epidural window, they sprout. So for the cross grafts, there's Tessa Gordon, Allison Snyder Warwick showed in rats that if these bridges, that the axons sprout with epidurals from intact to non-intact, and the more bridges had the decreased number of fibers. So the first bridge you got the most sprouting, you make a second window, gave you some, but not nearly as much. The mechanism behind it, I think, I mean, maybe someone much smarter than me would know why they sprout. We don't see that same spontaneous sprouting in motor. And so that's where we have to direct, like for the supercharge, we've looked at it, others have looked at it. Some say that they just change the environment. Others say they make connections. We followed through confocal microscopy that those axons made it to the muscle with functional connection. We did retrograde labeling and also showed increased number of motor neurons recruited. So when you transect distal to the coaptation and you dye it back. So I was not really mechanistically, I'm not answering your question, but from a scientific standpoint, which is what drives my clinical, like overwhelmingly positive, I want to do it all the time. It's just from seeing how these nerves will grow and do that function that we want.
Thank you so much.
Dr. Amber has a lot of questions. Dr. Amber, please go ahead.
Thank you so much to all of our panelists. I wanted to ask Dr. Agnew specifically what I think our classification for patients who need toe transfer is to cover the extremity with a groin flap, but you've moved into something more elegant, which is to use multiple tailored flaps for these patients. Can you talk to us a little bit about your pedicle management for these kind of situations?
Sure. So pedicle management, meaning planning for the second stage. So this was a patient who had the option of a lot of planning prior to, and my initial plan was to use the proximal radial artery at the end of the pedicled radial forearm flap as my inflow for the toe. But on the day of surgery, when I exposed the pedicle of the toe, he had a plantar circulation. So very short, very small recipient vessels for the toe, which a lot of choice words were shared in the operating room when I found that out. And so because of the size mismatch, I planned to graft. I did a vein graft. And essentially use the radial artery in the snuff box to the vein graft to the toe. That was the last time I didn't get an angiogram of the foot in preoperative planning for toe transfer. Because the plantar circulation is everyone's enemy. It's very, very uncomfortable dissection and very short. So had he had native dorsal, long pedicle, and larger size vessels, I would have gone end to end to the radial forearm flaps radial artery. I hope that answers your question. I initially thought I'd be splitting the flap and tucking the vessels in there, but then I was a little concerned about pedicle compression. So I ended up scooting the flap to the side and then defatting it later.
Excellent decision making. Thank you. For Dr. Morro, thank you for sharing some really complex cases with us. I really appreciate how you had broken down so many of these very intense problems with many parts into their subunits and approached each of those very thoughtfully. I was wondering if you'd had any experience with doing selective neurotomies in the hand, and if you could talk about that.
Rosa?
Yeah, we don't have a lot of experience because the patient cannot have retraction, otherwise the technique won't work. If there's any kind of retraction, you have to go for tenotomies. And most of the patient almost always have some kind of retraction. So we don't use it very frequently, but there are several techniques described. One is for the adduction of the thumb, to go to the motor branch of the median nerve. Another one is for the deformity of the for the spasticity of the interosseous muscles for an intrinsic plus deformity, and you also can go to the motor branch of the ulnar nerve. This is not a very easy dissection because you have to go deep through all the flexor tendons of the fingers. But it is described, and it can be useful if you select properly the patient.
Such a fascinating contrast to all the rest of the speakers who are trying to reinnervate things, and now we are talking about de-innervating.
I also try sometimes. I do both.
Of course. For Dr. Power, I was wondering if you could talk to us about your thoughts about transcutaneous electrical stimulation, which I know is much more commonly available for patients, and if you think that there's any benefit for that.
The stimulation that I was talking about is stimulation applied directly to the nerve. The problem with transcutaneous is that the impedance of the skin is so high that you can't get the current density to the nerve without it being painful to the patient that you could achieve with an implanted electrode or a handheld stimulator intraoperatively. So there was actually a comparative study done recently that looked at transcutaneous versus direct stimulation, and of course direct was better for nerve regeneration.
I just want to congratulate you on your publication from last year in PRS about refining the indications for the end-to-side transfer in pubertal tunnel patients. That's like required reading for all of my residents, and we use it extensively because it is so algorithmic and lovely for teaching. So thank you for that.
Thanks.
And then Dr. Moore, I was hoping you could talk to us a little bit about your decision making for the patient that you presented, where you waited about 2 months between the initial radial nerve reconstruction and the thoracodacical to triceps transfer before the distal transfers were done. I just was hoping you could talk a little about that.
Yes, thank you. I tend to do, when you have that big surgery of going into where I didn't know what I was going to find when I was exploring her radial nerve, and I had her at an early time point, so I think 3 weeks after her actual injury. And so I know there was time, and that I think was the reason of not trying to put too much into one day. I mean, she was even flying from California to get this procedure to me in St. Louis, but don't think the goal is to have a marathon day where she's under long anesthesia and I'm tired at the end. And those transfers are very nuanced. And I've gotten faster the more I've done. So that's both with the gentleman who I reconstructed as elbow ulnar nerve, the professional guitarist, as well as the CrossFitter. I just feel that I'm not sure what I'm going to find when these patients have a known injury, and then I can really focus my efforts to one segment at a time. If we were pushing against a time window, maybe 9 months, I would have done it all in one day. But that break in time allows the patient to have a shorter anesthetic, for me to keep a better bearing space, and then I would argue an equivalent outcome.
Very wise.
Yeah. It's Dr. Rajan.
My question is for Dr. Hollie Power. I've read your publication on triceps traction test, which we use for cubital tunnel syndrome. So I would like to know how do you choose whether to do a triceps sling or after translocation or flexopronator sling? How do you try that?
Yeah, thank you for the question. So the paper that she's referring to is talking about in situ cubital tunnel decompression with a stabilizing flap. And so at our institution, we often will use a little triceps muscle flap to stabilize the nerve, or a flexor pronator fascial flap. And we do this thing called a triceps traction test, where you basically, once you have your nerve released, you traction on the triceps and then range the elbow and see if that corrects the anterior subluxation of the nerve. And if it does, then you would do a triceps test, a triceps flap. And if it does not, then a flexor pronator flap. So that's how we use it in clinical practice. If the nerve is grossly subluxating over the medial epicondyle, then I would transpose it. I would not try and do a stabilizing flap. That's something that I think my fellowship really influenced me with Amy Moore and Susan McKinnon, to just do the full operation that you are confident is going to work, like from the get-go, particularly if it's a severe neuropathy. I don't want to have to go back. I want to do everything in the first go.
Thank you.
Dr. Morro,
Can we
I
have
think
the
there were
last
some
question? Can you have the last question for this webinar? Question from
Questions keep pouring in, Terence.
yeah, we'll have to wind up the session with the last question from Dr. Bharat Kadadi, who is also a great hand surgeon from India. He just needs to know the indication and the role of proximal row carpectomy in correcting the flexion deformity, especially in spastic deformity.
Question?
I'll repeat the indication and the role of proximal row carpectomy in correcting the wrist flexion deformity.
Yeah. When usually when we do soft tissue procedures, we don't do anything with the bones, with the carpus. But when we do a fusion of the wrist, we usually resect. We do a proximal row carpectomy for two reasons. So with this we will gain some space, so we won't have to lengthen so much the flexor tendons of the fingers. And the second reason is because we can use the bone, the bones to use it as a bone graft. But when we perform only tenotomies and tendon transfers, we don't do anything with carpers.
Okay. Thank you so much. Before we wind up the session, we'll have a quick closing remark from all these panelists and the moderators. I'll ask Dr. Amy Moore, quick 30 seconds closing remark.
I would just like to say thank you to all of those who attended and to all my panelists. It's great to love what we do and to get to do what we love, and to share it with all of you is just a true honor. Thank you.
Thank you. Dr. Hollie.
Thankful for the opportunity to be invited to present on this panel. So thank you very much, Dr. Jerome and the journal. And yeah, it's a great opportunity, and I learned a lot from everyone's presentation. So thank you.
Thank you. Dr. Rosa.
I just want to thank the opportunity to participate in this wonderful session. It's been an honor, and thank you very much. It's been very inspiring. Thank you.
Thank you. Dr. Sonya.
I'll echo the comments of others. I'm truly amazed and very honored to both do the work that I get to do on these patients and work with people like yourselves. So thank you very much for the opportunity, and great morning.
Thank you. Dr. Shija.
Yeah, Terence, I would like to make a concluding remark that thank you so much for inviting me and sharing the panel with such a illustrious speakers. I mean, women have left no bastion unturned, be it space science or surgical science, of course, with a lot of support from our male colleagues, family, as well as our mentors. So we are all fortunate to have such people in our lives. So let me quote one shloka in Sanskrit from Manusmriti. Yatra naryastu pujante ramante tatra devata, which roughly translates to English as where women are honored, divinity blossoms there. So that is the Indian belief. So gentlemen, if you want divine blessings in your life, do continue to support the women folk. But jokes apart, we really appreciate you, the chief editor, Terence, and the Journal of Hand and Microsurgery for arranging this wonderful talk. And it was really a joy to listen to all these amazing surgeons. Thank you so much. Really appreciate it.
Thank you, Dr. Shija, for kind words. Dr. Amber.
Dr. Rajan, I don't think I could think of anything better to say than that beautiful quote you just shared with us. I'm so grateful for the opportunity to join in this community. And even though we're going through such a tough time in the world right now, to have technology like this to bring us together and for the opportunity to share and learn from one another. So thank you for including me.
Thank you, Dr. Amber. Thank you once again, Dr. Amy, Dr. Hollie, Dr. Rosa, Dr. Sonya, Dr. Amber, Dr. Shija. This is an amazing webinar. We have learned many things from these talks. Thank you once again. Thank you for your concerns about India. We are reeling under, and definitely we do hope we'll come out of this pandemic crisis soon. Wishing you all safe and healthy at this juncture. Thank you once again, and have a safe and healthy. Thank you. Bye-bye.
Cheers. Thank you. Peace. Peace be with you all.
Thank you. Thank you very much.
Cheers.
Ma'am, nice words. I'm really enjoyed that. Thank you.
Nice webinar. Also really enjoyed it. Thank you so much.
We'll keep doing it. Thank you, ma'am.
Yeah, definitely. And we should have one topic. So much to ask them. I think this was quite a handful, actually.
Sure, ma'am. Completely agree with you, ma'am. I will keep this in mind, ma'am.
Definitely. All the best.
Thank you, ma'am.
Bye.